Hello everyone, my name is Dr. Ram Mohan Mishra. Today we are going to see a challenging case of an iris coloboma with a soft cataract in a young diabetic patient of 47 years old. The examination revealed iris coloboma with normal lens, no lenticular coloboma and no choroidal coloboma as well. Though the cup disc ratio suggested of a glaucomatous change, which was confirmed by the visual field analysis that we did, and the patient was having moderate glaucoma in both the eyes, and the guarded prognosis was explained. The pressure was not much, so we just decided to do a phaco right now. uh, and in doing phaco emulsification in patients with iris coloboma, you need to have certain extra care that needs to be taken, and as there is already a area of weakness in the inferior nasal area, as you can see, so possible complications that can occur is PCR, zonal dialysis, and vitreous loss from the area of weakness. It's a good idea to implant a CTR before doing the phacoemulsification into the bag to stabilize the bag, and also I implant the CTR through the main port and not the side port, as all as most people do. I find the main port in much easier to implant the CTR, and the talk of vitreous and the talk of AC collapse because of the visco leak is something that I do not really buy, because it's a very small CTR and it can easily be implanted through the main incision without much visco leak. Since I'm working in a charitable setup, the machine here has not been working really well since last 2-3 cases. So I decided to bring the nucleus out of the bag and do a supracapsular debulking of the nucleus. And the machine has been behaving very erratic. There is in last 2-3 patients I could see a lot of surge, and also the fallibility was an issue. So I did not want to take any risk, so I decided to do the supracapsular phaco. And you can see I'm just debulking the nucleus, and I have to manually feed the nuclear material into the phaco probe, and which is suggesting of the fallibility, which is practically nil or non-existent in this machine. So I just did the chopping maneuvers. I'll do the final chop again and then debulk the nucleus again. And yes, during emulsification I need to be mindful of not going towards the weaker area and be in the center as much as possible. And sudden collapse of the AC should be avoided. So instead of taking out the phaco probe after eating up the nucleus, I should have injected the visco before taking out the phaco probe, as this could have certain caused a certain collapse, and vitreous loss could have been seen through the area of weakness. But thankfully there was not to be seen in this case, and I did the routine bimanual IA and removed the cortical matter and made the bag ready for foldable IOL implant. In such patients you need to be careful in doing the rexes as well, and I like to do the rexes a little bigger and away from the area of the weakness. Hydroimplantation was done in such a way that the haptic was towards the area of weakness, and final visco wash has been done. While doing phaco in such cases, you need to be prepared with your backup of anti-vitrectomy if needed. And as also with CTR, like I use the CTR in this case, so, and also a 3-piece IOL would be an ideal choice to have as a backup as well. Thankfully it was not needed in this case, and the case was done. Do like my video and share my video. Thank you.